Sure, ma'am. So I'll start then. So good morning, one and all. Uh, so today I would be briefly talking about primary immune deficiencies. When should one suspect? And I think as pediatricians, we regularly come across children with recurrent infections. And over the last 5 years or so, the awareness on these group of diseases has really gone up. And there is definitely a need for raising further awareness so that these children are diagnosed in time. It is also important to note that now the diagnostic facilities are very easily available and accessible, at least in Bangalore, including genetic testing, and that is why more and more children are getting diagnosed in time. It is also important to highlight that we also have almost all the facilities to treat these children, including a bone marrow transplant. So objectives of the presentation would be to highlight that primary immune deficiencies are common and many medical specialists come across these patients to provide a clinical approach to the diagnosis of PIDs. Now, this is the first thing I want to highlight, that immune deficiencies are not seen only by pediatricians, but are seen by a host of specialties like pulmonologists, gastroenterologists, rheumatologists, hematologists, and physicians. And unless all the specialties are aware about these conditions, these children and adults remain undiagnosed. So this is the latest update on the classification given by the International Union of Immunological Societies. Now the primary immune deficiencies are better known as the inborn errors of immunity. And as per this classification, there are now more than 430 diseases. It is important to highlight that 65 new gene defects were identified only in the last 2 years, indicating that with advancement of molecular science, these diseases are the list is only going to expand further. The prevalence as a group, these diseases are very common. 1 in 1,000 individuals may have a primary immune deficiency. So these diseases by no means are rare diseases. Let's take up a few cases and understand how we can diagnose these conditions. This is a 10-year-old boy coming to us with pneumonia who requires hospitalization. And as you can see, the chest radiography showing infiltrates. Past history was significant. There were 2 episodes of ear discharge and recurrent skin infections. And interestingly, this boy had already developed clubbing by the time he came to us. The tonsils were absent. And when you see absent lymphoid tissue in a boy with recurrent infections, it is a straightforward diagnosis. It is X-linked A-gamma globulinemia. This is one of the most common immune deficiencies that we see in clinical practice. So when we performed serum immunoglobulin profile, all the immunoglobulins G, A, M were undetectable, and the B cells which produce immunoglobulins were absent. The B cell count can be easily ordered by doing a flow cytometry based test. For serum immunoglobulins, you need a plain vacutainer. For a T cell, B cell, NK cell count, you need a EDTA vacutainer. So this confirms the diagnosis of X-linked A-gamma globulinemia, which is a prototype of humoral immune deficiency. These children remain well for the first 6 months because of the transplacental transfer of immunoglobulins. There is complete absence of B cells, pan-hypogammaglobulinemia, and absent tonsils and non-palpable lymph nodes will be a very simple clinical clue. So the first message I would like to give is that whenever we see boys coming to us with recurrent sinopulmonary infections, please look at the tonsils. If the tonsils are absent, always order a serum immunoglobulin profile. One should have a very low threshold to get a serum immunoglobulin profile, which can easily clinch diagnosis in this case or in these scenarios. So this is a 41-year-old gentleman from Gujarat who was unwell from the age of 15. He had almost 20 hospitalizations so far. Each time he would get admitted with a chest infection and get treated with antibiotics. Subsequently, he started developing recurrent episodes of diarrhea and had almost lost 15 kg of weight. He was investigated by gastroenterologists. However, no clear diagnosis was offered. HIV test on multiple occasions was negative. So he performed a Google search, and with his Google search, he came up with a conclusion that he has got an immune defect because he's suffering from so many infections. And this is a case when I was getting trained in PGI Chandigarh. So this person, with a second search on Google, realized that PGI Chandigarh may be one center he can walk into to get a diagnosis. And when he came to us, he was literally carrying, as you can see, a bunch of reports which ran in few kgs. When he walked in the OPD, I still remember him telling to my professor that I have an immune deficiency. So he himself knew that he had an immune deficiency because he was suffering for years. And with these many reports, my professor asked me to make a diagnosis. So I really wondered how can one study so many reports in such a short span in an OPD. But then there was a clear message that my professor gave me, that whenever your medical reports run beyond 1 kg, there is no diagnosis. There is only one diagnosis, and that's a primary immune deficiency. So whenever you have a patient who is running from OPD to another, to multiple OPDs, carrying a huge number of reports, it is likely to be a primary immune deficiency. We performed a serum immunoglobulin profile. As you can see, all the immunoglobulins were low. They were below the -2 standard deviation, but the B cell count was 10%, which is normal. So you have an adult patient who has got hypogammaglobulinemia, recurrent infections, a normal B cell count. This is what we call common variable immune deficiency, the CVID. This is the commonest symptomatic immune deficiency that you see in adults, and it has got a very variable presentation. Commonly, these patients would present to pulmonologists and gastroenterologists. So this is a group of disease where you have hypogammaglobulinemia with normal B cell number, usually starts in second and third decade. They can have enlarged tonsils, splenomegaly, and to add to the issues, they can have a host of autoimmune manifestations. Now, this 25-year-old lady was unwell from the age of 9 with multiple chest infections, also had polyarthritis and ear discharge. Because of polyarthritis, she had been treated for possible rheumatoid arthritis by a rheumatologist, also had sought opinions from orthopedicians. With ongoing chest infections, when she came to us, she had already developed bronchiectasis. And before we could proceed further, we did an immunoglobulin profile, and there was pan hypogammaglobulinemia. This is another patient with common variable immune deficiency who presented with arthritis and recurrent infections. So unexplained bronchiectasis, one should always test for serum immunoglobulins. I don't think there is anything called idiopathic bronchiectasis unless you have done a serum immunoglobulin profile, because often these patients, when not diagnosed in time, develop bronchiectasis. So the message, recurrent sinopulmonary infections, please order serum immunoglobulin. So from the first two cases, it's quite clear that immunoglobulin profile can diagnose these conditions. And if you suspect an immune deficiency, this algorithm is very helpful. Immunoglobulin profile showing hypogamma, look at the B cell count. Absent, it's likely XLA if it is a boy. And if the B cells are present, more likely common variable immune deficiency. The second set of cases, this is a 5-year-old boy who came to us with non-resolving pneumonia. Despite 3 weeks of IV antibiotics, there was no response. We performed a lung aspirate that showed aspergillus. So this is a fungal pneumonia, very, very unusual. And that's where we performed the NBT dye reduction test, the nitroblue tetrazolium test. As you can see here, the neutrophils, when stimulated, will show a pigment formation, which is normal, whereas in the patient, there is no pigment formation, basically telling us that the neutrophils are not doing their job properly, though they are present. This is chronic granulomatous disease. So chronic granulomatous disease is a condition where neutrophils are present, but there is a defect in intracellular killing of the organisms because of an enzyme deficiency. Aspergillus is a signature pathogen. When you see organisms like Serratia, Burkholderia, Pseudomonas, or multiple episodes of staphylococcal infections, do think about chronic granulomatous disease. A simple screening test like nitroblue tetrazolium test is very helpful. This test is readily available in Bangalore, and the cost of the test is around 300 rupees. So it is very cost effective. So these patients with chronic granulomatous disease come to us with suppurative infections like recurrent suppurative lymphadenitis, non-resolving pneumonia, empyema or lung abscess, liver abscess, and they can also have inflammatory colitis. This 4-year-old boy with multiple episodes of pneumonia from 2 years of age then went on to develop rib osteomyelitis. Because he developed rib osteomyelitis, the rib was aspirated by the surgeon and the histopathology showed a granuloma. So AFB was not isolated, but there was granuloma, and hence this patient was started on antitubercular therapy. But then he went on to receive antitubercular therapy almost 3 times before he came to us with every episode of pneumonia. He had also developed a swelling over the cervical spine, and the MRI showed vertebral osteomyelitis. So this was something very unusual. And when investigated with the NBT and a DHR test, dihydrorhodamine dye test is another test that we do for screening of chronic granulomatous disease. Those tests were abnormal, and this is a patient with chronic granulomatous disease. As the name suggests, these patients develop granulomas. So whenever you see a granuloma, there is a huge list of differential diagnoses. Granuloma is not always equal to tuberculosis, and whenever we see granuloma, CGD is an important differential diagnosis. So non-resolving pneumonia, unusual organism, or presence of granuloma, one should always think about an inborn error of immunity. This 2-year-old girl who came to us almost 2 years back, She weighed only 5.5 kg, had significant failure to thrive with recurrent diarrhea from 6 months of age, and had been hospitalized multiple times. The working diagnosis was malabsorption, IBD, and other stuff. And differential diagnoses that were offered were like CMPA, cow's milk protein allergy, cystic fibrosis, and all the workup, including an endoscopy, was non-rewarding. And this child was also tested for HIV and was negative. Subsequently, when we did an immunoglobulin profile, as you can see, IgG-A were very low, but the IgM was very high, and this is a child with hyper IgM syndrome. Again, a simple immunoglobulin profile clinched the diagnosis. So what's hyper IgM syndrome? We all know that the B cells first produce IgM in response to an infection. Subsequently, there is a switch and they produce other antibodies. This switching requires B cells to talk with T cells via CD40-40 ligand interaction. If there is a deficiency of any of these proteins, this switch does not happen. The B cells only produce IgM, they don't produce other antibodies. That's hyper IgM syndrome. And since IgG is missing, these patients need IVIG infusions. So this patient came to us with recurrent diarrhea. So whenever you have chronic or recurrent diarrhea, please think about an inborn error of immunity. 7-month-old girl child from Bangalore comes to our she was hospitalized with severe pneumonia. She also had oral thrush. HIV test was negative. The chest radiograph did show pneumonia, but importantly, this is an infant and the thymic shadow was missing. So absent thymus in an infant is a very, very important clinical clue. The hemogram showed neutrophilic leukocytosis, but on a closer look, the lymphocytes were only 8%, absolute lymphocyte count being only 1200. This is lymphopenia. Any lymphocyte count less than 3000 in infancy is lymphopenia, and persistent lymphopenia in an infant only means one diagnosis, and that's severe combined immune deficiency. This is a serious immune deficiency that you see in young infants. They come to us with opportunistic infections like pneumocystis jirovecii pneumoniae, oral thrush. They often fail to thrive, and this is a fatal disease. Often children die within the first 2 years, and there would be history of a sibling death in the family. So if you have this kind of presentation, look at the differential counts. If there is lymphopenia, if the chest radiograph is not showing thymic shadow, you are almost certain that you're dealing with severe combined immune deficiency. Subsequently, you look at the T cell number. If it is low, you have got the diagnosis. These children require an urgent bone marrow transplant. As you can see from this picture, this is a child with severe combined immune deficiency, mother being the donor. This child was transplanted almost 2 years ago and is doing fine. This is another child who came all the way from Kolkata with severe pneumonia, non-resolving pneumonia. And this child also had severe combined immune deficiency, received a bone marrow transplant, and is almost 6 months post-transplant doing fine. So transplant is a feasible option in these patients. This is a 3-year-old boy who comes to us with pneumonia. The hemogram showed thrombocytopenia. So the working diagnosis was pneumonia with sepsis. However, the family history was significant. The first boy had died at a young age with bleeding manifestations. However, we did not have any records to assess, but we knew that there is a significant positive family history. We reassessed the index child. The platelet count was low. The mean platelet volume, which is the size of the platelets, we looked for it and it was only 4.5 femtoliter. So there was microthrombocytopenia, small platelets. There is only one diagnosis for this situation, and that's Wiskott-Aldrich syndrome. It's an X-linked disorder, and that's possibly the first child also had VAS. So in every child with persistent thrombocytopenia, please look at the mean platelet volume. They are often misdiagnosed to have chronic ITP. ITPs usually have high mean platelet volume. So if you have a low mean platelet volume in a setting of persistent thrombocytopenia, this is likely Wiskott-Aldrich syndrome. This 1-year-old boy who had petechial rashes over the body also had thrombocytopenia, mild anemia, and he was being treated as ITP by the hematologist. Subsequently developed these kind of rashes over the earlobes and the sole. This is a vasculitic rash. There is no reason why a child with ITP should develop vasculitis. So reassessed, the platelet count was low. However, the mean platelet volume was also low. So again, you have a situation where you have microthrombocytopenia. This is Wiskott-Aldrich syndrome. And patients with Wiskott-Aldrich syndrome not only come to us with infections, but with autoimmune manifestations like cutaneous vasculitis. This is another child who had chronic eczema, was under the care of dermatologist. For some reasons, when a hemogram was performed, this child had thrombocytopenia. This combination means one diagnosis, and that's Wiskott-Aldrich syndrome. So when you have eczema, recurrent infections, thrombocytopenia, Wiskott-Aldrich syndrome should always be thought of. This is a 1.5-year-old boy from Gujarat. He came to us with recurrent diarrhea from 8 months of age. So infantile onset diarrhea with bloody stools. GI studies showed colonic ulcers, and biopsy was consistent with features of inflammatory bowel disease. But this is an IBD starting at a very young age in an infant. So when you have IBD starting before the age of 6, we call it VEO, very early onset IBD, and this is almost always a monogenic disease or a inborn error of immunity. So when we performed genetic studies, there was pathogenic mutation in the IL-10RA gene. So this is interleukin 10 receptor deficiency presenting with very early onset IBD. What is interesting that this child received a bone marrow transplant and is doing fine. So now you can treat IBD with bone marrow transplant provided it's monogenic and is diagnosed in time. So this is how molecular diagnosis can change the outlook for these children. This is another boy from North Karnataka who had these grotesque looking skin lesions. These were basically pyoderma gangrenosum lesions which would heal with large scars. On hemogram, he had persistent leukocytosis, but this was remarkable, as high as 90,000. Even when he did not have infections, his counts were high, and this was all neutrophilic. This is what we call the leukocyte adhesion deficiency. This degree of neutrophilia is not sepsis, this is leukocyte adhesion deficiency. And as we know, leukocytes normally are in the bloodstream. If there is a microbial invasion in the tissue, the leukocytes leave the blood vessel and then kill the pathogens, for which leukocytes must adhere to the endothelium via CD18. And if that protein is missing, leukocytes don't adhere. We call it LAD, leukocyte adhesion deficiency, and you get remarkable neutrophilia because all the neutrophils are in the bloodstream. So this is another 3-month-old child who came to us with omphalitis, subsequently developed this very large perianal ulcer, but there was no pus formation. Again, remarkable neutrophilia, persistent neutrophilia. This is leukocyte adhesion deficiency. This child received bone marrow transplant and is doing fine. So high neutrophil counts is not always sepsis. Very high neutrophil counts, think of LAD, non-healing ulcers with high counts. It's almost always leukocyte adhesion deficiency. Again, flow cytometry based test and genetic test can easily diagnose these conditions. This 9-year-old boy came to us with inguinal and submandibular lymphadenopathy for the past 10 days. And he also had low-grade fever, but past history was significant. At the age of 4 months, this child had left axillary adenitis, possibly BCG related, and had received anti-tubercular therapy. At 5 years of age, this child had another episode of right axillary adenitis. The biopsy had shown AFB, acid-fast bacilli, and this child received second course of anti-tubercular therapy. So with a significant past history, now the child presented to us with fever and lymphadenopathy. And this is a submandibular lymph node, as you can see, the biopsy of which showed granulomas. But interestingly, the tissue gene expert and even the ZN stain, everything was negative, but the MALDI-TOF showed salmonella enterica. So this is basically disseminated salmonella. So again, a very unusual manifestation of salmonella with a background of tuberculosis. We performed a genetic test and it showed mutation in the IL-12 receptor beta-1 gene. This is MSMD, Mendelian susceptibility to mycobacterial disease. As the name suggests, these patients have susceptibility to mycobacteria and also salmonella. So whenever you see disseminated BCG or recurrent salmonellosis or unusual salmonella manifestation, please work up. This 5-year-old girl from Bangalore had severe atopic dermatitis from the age of 2, multiple courses of steroids with no relief, very high IgE levels more than 2,500. But to add to it, she also had some viral infections like warts and molluscum contagiosum, and there was some mucosal hyperpigmentation. Genetic studies now confirmed DOCK8 deficiency. This is autosomal recessive hyper IgE syndrome. But what is important to remember, whenever you see severe atopy with infections, you should always think about an underlying immune deficiency. This 10-year-old boy from Bangalore who had blood in stools from 4 years of age, chronic diarrhea, significant weight loss. So he had a lot of GI issues, and then developed deranged liver enzymes. Liver biopsy was inconclusive and HIV was non-reactive. So to be frank, we had no clue of what we were dealing with because this child was investigated by the gastroenterologist and the hepatologist and there was no clear diagnosis. What actually was an eye-opener was the family history here, because the father, who is 35-year-old, had autoimmune hemolytic anemia right from a young age and had received multiple courses of steroids. He also had diarrhea, which was steroid responsive, possibly autoimmune enteropathy. Very interestingly, his mother, the paternal grandmother, who is now 55, also had autoimmune hemolytic anemia with chronic diarrhea, which was steroid responsive. So what we clearly knew that this is a genetic disease, possibly autosomal dominant in inheritance. And that's where we performed a genetic study. And as you can see, all the 3 family members were tested positive. And this is CTLA haploinsufficiency with autoimmune infiltration. This is a new immune deficiency where patients present to us with polyautoimmunity, and since it is autosomal dominant, it can run in family members. And as you can see, these patients need not die at a young age and can suffer even in adulthood. This 6-year-old boy who came to us with diabetes mellitus. Now, this is a case where endocrinologists must be interested because many of our patients can be in the endocrine department. So this is a boy who starts with type 1 diabetes mellitus, then has hypocalcemia and hypoparathyroidism, chronic diarrhea, which is steroid responsive, so autoimmune enteropathy, and later develop polyarthritis. As you can see, there are multiple autoimmune manifestations, plus there is endocrinopathy. And so you have polyautoimmunity, entropathy, polyendocrinopathy. Whenever we have this combination, we do think about a defect in T regulatory cells. So these are the cells which keep immune system in check. And if there is a deficiency, you end up getting autoimmunity. A genetic study confirmed that this patient had LRBA deficiency. So another disease where you have polyautoimmunity and endocrinopathy. So whenever you have multiple endocrine manifestations in a given patient, or when you have autoimmunity starting at a very young age. So recently we had a child who has neonatal onset diabetes mellitus, and we have diagnosed an immune deficiency. So basically, when autoimmunity or endocrinopathy starts at a young age, one should always investigate. So over the last 4.5 years, we have now diagnosed more than 200 patients, close to 208 cases. Almost 30 of these patients have received a bone marrow transplant. So these diseases by no means are rare, and as awareness spreads, I'm sure we are going to diagnose more. So all the several specialties must think of a PID. And I just wanted to highlight to the pediatricians here and those who would listen it, that we have a fellowship in Pediatric Immunology in BMT. This is a 2-year fellowship. Dr. Rashna is our first fellow, and we are possibly going to get the second fellow in April 2022. The applications are out. Dr. Stalin and Dr. Raghuram are co-faculty, and we hope to get the second candidate soon. And this is a small book on primary immune deficiencies that I tried to author. This is called Primary Immune Deficiencies Made Simple. This is a 150-page handbook. Should be useful for busy pediatricians and medical students. I would be happy to take a question. Thank you.
Thanks, Dr. Sagar. Let's see if anybody else has got any questions. After that, I'll take my turn.
Sure, ma'am.
Any questions from anyone else? I'll probably start with this.
Yes, ma'am.
So we had a couple of kids recently, and we weren't quite sure where we stand. So we had a child with, or we still have a child with chronic meningitis, which is ongoing, and that is like post MISN treatment. So I'm just trying to find out, where do we stand there? This family hasn't yet got their test done. Are we, in the setting of a child who has received steroids for some other illness, and then subsequently they develop an infection that is not fitting to the regular course. When do we suspect that? When I talk to the ID team, they say, chronic meningitis is something possible, and after 3 months also we have given the IV antibiotics. It is nothing unusual, as long as we are like giving the right set of antibiotics. And we have done intermittent LPs as well on that child. We didn't grow subsequently any bugs, but the biochemistry just never normalized. So I'm just curious, when do we kind of think about that in these kind of cases? How do you kind of approach these kind of cases?
Yeah, ma'am. So that's an important question. I remember this child. So I think this child was complicated due to several facts. Number one, the steroid exposure. Number two, I think the first episode of meningitis was partially treated. And whenever we have partially treated meningitis, its complications like ventriculitis, I think they are bound to happen. And that is one particular setting. If you have a partially treated meningitis going on to ventriculitis, I would possibly not think of an immune deficiency on a very strong ground unless you have a positive family background, or if you have a past history that is significant, or if you have an organism which is unusual like Neisseria meningitis, or if you have I would say something in the blood reports like lymphopenia or neutropenia. So that would be my answer to that question. So having said that, whenever we have a child with meningitis, the organism is important. Like we know that Neisseria meningitis is known to happen with the terminal complement pathway defects. So if the organism is unusual, definitely we would investigate. Or if it is a second episode of meningitis, then we need to look at this. We will look at the CSF leaks. Those, that is one possibility, or an immune deficiency, because I have one boy with X-linked agammaglobulinemia who had 3 episodes of meningitis and then was diagnosed to have XLA. So yes, in such a situation, we would like to do the preliminary screen, I think, which we did in this patient, like an immunoglobulin profile, and look at the lymphocyte subsets, especially in an infant, to rule out severe combined immune deficiency. Otherwise, in that particular child, my suspicion of immune deficiency was low.
Thank you. Any other questions from anyone else?
Sir, we need one more class, approach to primary immunodeficiencies. Because, hello?
Yeah, you're
Most
audible.
of the time we will end up in sending just PID panel. So just we need a class on approach to primary immunodeficiency, so that how to suspect them initially.
I thought this class was for the same thing. So basically, it's a case-based discussion. So only these cases will help you learn. There is no textbook on primary immune deficiency that will help us learn. Our cases are the way we learn these, how to approach. So to make it simple, if you have a patient with second episode of chest infection, recurrent pneumonia, you would investigate. Recurrent diarrhea, you would investigate. Unexplained failure to thrive with infections, you will investigate. And if there is polyautoimmunity, you will investigate. So it is basically a clinician's capacity to elicit a good family history, a good past history, and reviewing the records that you have has always helped us diagnose these conditions. So whenever you approach a child with recurrent infections, the first thing is to think about a PID. The second thing is to take a good past history and family history and note down the microbial profile. The third thing is to look at the lymphocyte counts, the neutrophil counts. And the next thing is to broadly categorize them into a B cell disorder or a T cell disorder or a phagocytic defect. That you can do based on the microbial profile and based on the type of infections that you have got. And the family history helps you to basically tell what could be the pattern of inheritance. And once you have categorized them into one group, so if you are dealing with a B cell disorder, you look for immunoglobulin profile. If you're dealing with a T cell disorder, you look at the T cell subsets like T cell, B cell, NK cell counts. If you are thinking about a disorder with a phagocytic defect, then you look at the NBT and DHR because you are suspecting chronic granulomatous disease. What I would also strongly request and suggest is to go through the book. If you haven't got one, I can give you a gift. This book on primary immune deficiency. I think many pediatricians who have read it, I think they have come back and told me that it is useful because it is a small book and you can always refer it when you are practicing.
Thank you, sir.
Thank you so much, Dr. Sagar. I have a very quick question for you. You know, when you must have received so many referrals from pediatricians and all of us, how do we make sure that we have referred to you properly?
No, ma'am. Basically, the thing is, I don't find any challenges. See, as long as we are suspecting and we are working them up, this would solve a purpose. For example, if there is a suspicion on your part, you can definitely, as we are doing, call me and then we can investigate. My only request would be that they can come and meet me once in my OPD so that if there is something that I missed at the first go, we can close it. So I think that should take care of it, ma'am, because as far as the IP patients are concerned, we are definitely investigating them and following them up. And the OP patients, they can come and meet me in the OPD. I don't see we are really missing any patients who are coming to us. My thinking right now is we are not getting a lot of referrals as of now, but from this region. But once we start getting referrals, I think we'll be able to solve them. Recently, we had a patient who came from a senior pediatrician in this region, and he had candidiasis for almost 4-5 years. And we performed the test, and now he has got this STAT1 gain of function defect. So I think once we spread the message, we get the referrals, we will be able to close them, ma'am.
Okay. Thank you so much. That was very